I focus. So this club you guys have is focused on like medical devices and apparatuses, correct?
Yeah.
And just by show of hands, how many people are looking into getting into healthcare or medical field of some sort? And have any of you been exposed to shadowing in the operating room environment or some sort of healthcare environment? Like a good portion? All right. Well, if I need to explain anything more detailed, just please stop me. But I'll start with a slideshow here. So I want to talk about technology in anesthesia and how we implement technology, devices, medications, different things of that nature from the beginning. All right. All right. So you can see the slideshow now, right?
Yeah.
All right. Perfect. So here's just a picture of a nurse anesthetist or anesthesiologist providing some anesthesia care to a patient. And what I kind of like about this photo is I have a lot of trainees, and I find as the generations continue, people get more and more hyper-focused on technology. They almost forget sometimes just to even look at the patient. They're staring at the monitors, staring at all the devices to tell them something, but I want you all to kind of think about technology as an adjunct and not as like an absolute replacement for other skills, like just as interacting with patients, interacting with people. We have to look at it more like an adjunct rather than an absolute endpoint. So just overall, we'll talk about anesthesia, what it is, kind of go over some of the history of it in brief. We'll talk about advances in safety over the past century or so, and it ties in very closely to technology and device implementation. So I think it's good to go over both of those in parallel. And then we can briefly go over a timeline of major technological advancements. We'll talk about where we are now and how practice is evolving in current day. And then we'll discuss kind of how do we look at devices, technologies, new therapies, how do we look at them from a 30,000 foot lens and determine what are the conflicts of interest, how do we know if this is actually something that's going to improve patient care and be helpful, or is it just something that's marketed very well and might not be the greatest thing for our patients. All right, so in general, anesthesia, for those who aren't aware, the definition is insensitivity to pain, which can be induced by injection of medications, inhalational gases, using medication to numb nerves, really any kind of therapy that helps patients either have less pain or be unaware of surgical or painful procedures. In the United States, it's performed largely by either advanced practice nurses such as myself, which certified registered nurse anesthetist is the official term, or physicians who are anesthesiologists. Many settings we work as a team, work as a care team where we both provide the anesthesia and work together taking care of multiple patients. Some places certain nurse anesthetists practice alone, physicians might practice alone, but that's becoming more rare as time goes on. And the technology has greatly enhanced safety over the last century, as we'll see. So there's just a picture of Penn Presbyterian Medical Center. It's Penn's Level 1 Trauma Center. So this is where I primarily work, along with David's dad. And I'll just show you a quick video. I just want you to pay attention to all the devices and everything that's going on. It gives you a highlight of coming into the emergency room, going up to the operating rooms, and some of the special therapy suites that we have. Just let me know if you can hear it okay once it starts. All right, trying to get full screen. This isn't showing up full screen for you, is it?
No.
Well, Well, that's fine. We'll just watch it the way it is. I can't get the full screen. So let's come into the trauma bays here. There's 5 trauma bays. Each one is set up to receive a patient from the helicopter or from the street with multiple injuries. Here's a CT scanner. That's how you get quick images of 3D images of patients' bodies successfully. Then we have the elevator right outside the trauma bay to get up to the operating rooms. And this is an example of an operating room that we can use for a trauma case. The anesthesia providers are here at the top, ahead of the drape by the machine. This is one of the cardiac operating rooms. And it has ability to do x-rays with that device. That's a heart-lung machine. But you can see all the technology just parked around in the halls here. This is more x-ray equipment. I'm sorry about this. I don't know why the connection is. And here's the recovery room where people go right after anesthesia. This video is not working out as I planned. Okay, well, if we can't get this to play, I'll just give you some thoughts. So this is the recovery area. Patients come in here. It's set up like a giant circle around 2 central nurses stations, so they have access, so that the nurses have access to all the patients. And then I could fast forward here. All right, what I'll do, I'll send this video to you, and you could share it with the group later. Let me just get back to where I was here. All right, just give me 1 second. So as we can all see, technology is not perfect. All right, so back to the PowerPoint. My point of that video, I'll send you so you can see the rest of it. It shows an interventional radiology suite where they can do procedures with X-ray to get into very tiny blood vessels and different things like that to stop bleeding or do therapies. And they also show like the cath lab where they can go into the heart vessels and do things for patients who have heart attacks and that sort of thing. But it just shows there's such an immense amount of technology that we use now in medicine. And along with that comes great responsibility to determine if, one, it's effective, and two, if it's actually helping our patients. All right. So the first, as technology advanced, our mortality rate, which is one of the most important indicators, if not the most important indicator with anesthesia, has reduced significantly over the past 50 years. So it has gone from, in developed countries, the anesthetic deaths per 10,000 cases have been reduced to about one anesthetic-related death per 10,000 cases, and 20 perioperative deaths per 10,000 procedures. So perioperative deaths means somebody has a mortality within the perioperative period, including like pre-op, intra-op, during anesthetic, post-operative, and going into the ICU or recovery area. The issue is that in developing countries, those that are like low socioeconomic status, the rates are still as high as they were back in the 1950s here in the US or in other developed countries, up to 20 to 28 anesthetic-related deaths per 10,000 anesthetics. So we're looking at rates that are 20 times higher in developing countries. And it could be related to access to technologies, but it could be a number of confounding factors which we really can't determine. The highest risk patients are newborns or children under 1 year old, elderly, male patients, those getting general anesthesia, which is a deeper level of anesthesia to make sure they're absolutely unaware, and emergency surgical procedures. And the types of surgeries that carry the highest risk are cardiac surgeries, thoracic surgeries like in the patient's chest for their lungs, surgeries on big blood vessels, on their stomach, GI tract, and children and fractures and different kinds of bone surgery, orthopedic surgeries. So just to show some pictures here, can you see the whole slide, or is my face still blocking it?
No, we got it.
It's okay?
Yeah.
Okay. So these are three separate pictures. The one in the bottom left corner this is right around the turn of the century, right around 1900. This is what an operating room looked like. They called it an operating theater, and a lot of places still call it this because the only way to really observe and learn from procedures was to be present in the crowd. So you have a bunch of surgeons, medical professionals sitting up here in the theater seats observing the operation. You can see there's very little advanced technology here. They weren't, the video wasn't available, so they couldn't record this to teach. Pictures were available, but really everything was hand documentation. If you needed to find information at this time, you had to physically go get a copy of a journal from a library or another hospital to see how they were doing procedures. There was no Google search, Google Scholar. There were no data banks where you can look up any study you wanted on the internet at any time. So if you can imagine, it was kind of difficult to advance technology back in those times. Then you have like 1950s era where the top right corner, there started to be more technology. You actually have lights in the operating room. You're not relying on sunlight to do an operation. You can start to operate in the dark and at nighttime. People are wearing masks. You have a bed that can function with some cranks and levers. There's like syringes, different stuff like that. So these are all technologies. We don't think of that as advances in technologies and machines, but they are important advancements that have occurred. And then there's like a modern day hybrid cardiac operating room here on the bottom right that has X-ray equipment, a bunch of screens, all kinds of monitors, all kinds of devices. So you can see how much it's advanced over time. All right, so another major advancement in technology was documentation. The first anesthetic ever performed, at least in the literature, was in 1846 when a dentist gave somebody ether. I don't know if you guys have chemistry lab, but ether is often used as a solvent. But it was actually the first anesthetic used as well. An anesthetist who would either be a medical student, a nurse, or sometimes a junior physician would soak a rag in ether and just hold it over the patient's face until they fell asleep. The first record of the anesthetics didn't even occur until 1894, so it was about 50 years from the first anesthetic that was delivered before regular record keeping occurred. So this was a huge advancement in safety. Let me go back one. All right. Because now you can look at previous records and see what kind of things worked, what kind of things didn't, rather than just relying on word of mouth. And then this eventually became standard in 1950 to keep records of every anesthetic that was performed. Currently, we use electronic records. So this has, it's supposed to be EHR, electronic health record. It's become a standard of practice over the past 10 years or so, maybe a little bit further back. So this allows automatic record keeping of all the vital signs in the OR, and we get to collect data more cleanly. It's available for doing research. It's available for going back and checking to see how we did it, and just taking care of patients better, having it available. And the most recent advances in technology and devices have this thing called a clinical decision system, where as you're performing anesthesia, the health record might give you some safety nudges, like, are you sure you want to give that medicine? This patient might have an allergy to it, or the patient looks like their blood pressure's been low for a couple of minutes. Do you want to do something about it? So the system itself can help the practitioner to catch on to things that they might be missing. And artificial intelligence and algorithms are part of that, because they recognize these trends and then they can give feedback based on the inputs. So this helps reduce errors and alert the anesthetist to possible problems, but it is not a replacement for clinical decisions. It's just an adjunct. So to continue with advances in safety and technology, one thing we do with anesthesia, just to give you an idea, when a patient goes under anesthesia, they go to sleep for surgery. There's different levels of anesthesia, but if they need to be under what we call general anesthesia or deep level for a very stimulating surgery, we often put a breathing tube in to help breathe for them. Patients are not aware of it, but this advancement didn't come along until 1928. Before that, patients just had to breathe spontaneously, and if their level of anesthesia got too deep, there was really no great way to support their breathing other than like lift their jaw up. For anybody who's taking CPR classes, like a chin lift or something like that. So the first device that advanced that was an endotracheal tube, which is a long plastic tube with a cuff on it that you can inflate, and when you put it in somebody's windpipe, it can protect their lungs and breathe for them while also protecting from any kind of aspiration of things that might have been in their stomach from eating previously or anything of that nature. So this was a huge advancement in safety. And in the 1950s, they developed tubes that were also readily available for children. But you can see it took, again, almost 25, it almost took another 20-some years, 25 years before they advanced this technology for children. Nowadays, we use things with like cameras, we use all kinds of fancy equipment that with fiber optic technology where we can use a camera to steer into people's airways and know exactly where we're putting breathing tubes and managing difficult airways of that nature. And that technology is continuing to develop more and more rapidly. But still to this day, despite all these advancements in technologies, there's still plenty of room for improvement in things as simple as communication and teamwork when emergencies arise. So here's I just threw in a few pictures of airway devices, because when it comes to anesthesia, airways, breathing are one of the main things that you deal with. Top left, can you see my pointer on your screen?
Yeah.
Okay, so the top left here, this is just this simple endotracheal tube that goes into somebody's airway. This is a laryngoscope. by today's standard, a laryngoscope is what we use to get a view of the patient's like vocal cords to put this tube in the right place. Um, by today's standard, this is pretty much old technology, but we do use it on a daily basis. But at the time, this was cutting edge. When this first came out, there was no other way to put in there was no other way to protect somebody's airway. Now we've developed things like right next to it here, there's a video laryngoscope where it has a camera on the tip, so you can see on the screen, multiple people can look at it at the same time. And all the way to the right is a fiber optic bronchoscope, so you can actually use a long, thin tube with the end of a tracheal tube on it to steer down into the airway if you have a patient very difficult or you want to do it while they're still awake, while just using numbing medicine in their throat. So that's a possibility. And then we have all kinds of other devices like this thing right here to the left in the middle is called a laryngeal mask airway. It can be used by inexperienced providers to just kind of pop it in the airway as a rescue. And ambulance crews can use it, dental offices can have it on hand, and it gives you the ability to bypass all this tissue that can block an airway, and you can help breathe for the patient. We have these high flow nasal oxygen that blows oxygen very fast and helps oxygenate patients who are having a hard time. And then all the way to the right, we have this is a robot that's an intubating robot. Now, I wanted to show you this because this is an example where technology gets a little too crazy. So it seems like an awesome idea. It was probably very exciting to study, but there's a clear reason we never use this, because all it really is taking the practitioner's hands away from putting the tube in directly and putting all this complex, bulky robot material to do the same exact thing with no increase in safety, no increase in effectiveness, and a lot of increase of cost. And then there's all the way down to we can use a system that pumps the blood for the patient outside of their body, gives it oxygen, takes out carbon dioxide, and bypasses the heart in a patient who this airway rescue won't work. Their lungs aren't working. So we have the ability to artificially work as a heart and lungs for the patient until they recover from major respiratory infections, heart failure, different major health problems. So we have that technology now, although we don't implement it unless it's a last resort, because outcomes are not always the greatest if we have to do that. And then in the bottom left is like a surgical airway, but like a rapid ability to put an airway in somebody if you can't put anything from above. And this is like what we'd use in an emergency to rescue a patient. So here, just to show you some technology advances in anesthesia. Sorry, this screen's blocking my view. Okay, so here's some machine safety. In 1941, the first publications came out to ensure that we were delivering adequate oxygen to patients. So I don't know how how many of you had an anatomy class or how many have discussed like some gases and chemicals at this point, but just for an idea, the first anesthetics were ether, nitrous oxide, and chloroform. Now, nitrous oxide, if you deliver just nitrous oxide to a patient, they won't get enough oxygen to supply their body. So early anesthetics that use nitrous oxide, patients would not be getting oxygen and could have all kinds of problems, brain damage, any of those sorts. So it wasn't until the 40s that somebody decided that we better ensure patients are at least getting 21% oxygen, which is what we breathe in the room air around us. So it limited the ability to deliver more than 79% nitrous oxide. Then we also decided we have to, when you breathe, you get rid of carbon dioxide. You breathe in oxygen, you exhale carbon dioxide, the opposite of what trees do. That's why everybody talks about planting trees to absorb carbon dioxide and provide more oxygen in the environment. So if a patient's not breathing under anesthesia enough, they're building up carbon dioxide, and eventually that causes all kinds of issues for your body. We added something to this breathing circuits so that you can absorb that carbon dioxide. That's called soda lime. It's the same substance they use in submarines, so that all the all the sailors on the submarine, they're exhaling all this carbon dioxide. They have to do something with it. So the soda lime absorbs it there. Even when a submarine sinks to the bottom of the ocean, they just dump soda lime on the bottom of the floor to keep absorbing it until somebody comes and rescues them. And then there was also the issue, how do we know we're delivering the right gas? Maybe the wrong gas was filled in the tanks. It wasn't until the 90s till we actually measure what gases are coming out of the machine and coming out of the patient. So in the 1990s, we finally have the ability to measure those gases and ensure we're delivering what we want to deliver. Here in the bottom left, this is called an ether screen. The early anesthetics, you would just put a rag or a gauze soaked in ether, or put that over the patient's face and just drip ether into the gauze, and that's how they would titrate anesthesia. Then in the middle, the machine started to advance. You can actually put an anesthetic in a breathing circuit, but you didn't really know how much you were delivering. You just kind of filled it up, and you had a bypass valve. And then to the right, they're getting more and more advanced, where they actually have meters. Okay, it looks like we're going to end in 10 minutes. I mean, I guess we could just jump back into the meeting to finish up once this cuts out. I'll try to move a little faster. All right. So here's a modern day anesthesia machine. You can see there's a lot more on this. There's a monitor up here that measures vital signs, heart rate, oxygen levels, blood pressure, the carbon dioxide patients are exhaling, their temperature, all that kind of stuff. Then there's a ventilator screen that when you're breathing for the patient, you can set the pressures, how much volume you're delivering, all kinds of different settings for the patient. These are different anesthesia gases plugged in here, so you can choose the gas you want to use. And then over here you have a computer for your documentation and to access the health record, access tests, any kind of tests the patient have, communicate with other people on the computer, and just document what's going on as you go. So monitoring, how's that changed over the years? Originally, can you see this in the top right? In the 1930s, we just measured anesthesia by how big are the patient's pupils. We didn't check blood pressure. We didn't check heart rate. All we did was make sure the patient was breathing, watch their pupils, drip the ether into the mask, and determine their level of anesthesia based on that. As you can imagine, a lot of patients went with very low blood pressures and low oxygen, and the mortality rate was much higher in those years. In the 30s, electrocardiogram came along, but it would take 2 more decades before we could actually watch the rhythm of the heart during the anesthetic. In the 1950s, their medications came around right around that time where we would be able to relax patients' muscles, but we had no real monitoring technique of how do we know they're fully recovered from it. So patients would come out of anesthesia, but they'd be very weak, and they would still have risk of like breathing problems. So then the monitor came along where we could measure with like electrical stimulation how much paralytic was still on board. In the 1980s were the first actual standards with what we had to do with monitoring. So continuous EKG, blood pressure, heart rate on the 5-minute intervals. So every 5 minutes we checked all these things. And then some way to detect that the patient keeps breathing and having alarms present to alert the anesthesia provider if something was going wrong. And then in 1989, 1991, respectively, we came along with this measure. I don't know if anybody's familiar, it's called pulse oximetry. So it's like a little clip on the finger. It tells you what's the oxygen level in the patient's blood. So you can tell if their oxygen levels are dropping. And the capnography is how much carbon dioxide the patient's breathing out. Those were revolutionary because it allowed us to very carefully catch breathing problems early. Please stop me if you guys want to have any questions, but we'll talk at the end as well. So another big part of anesthesia is what's called regional anesthesia or neuraxial anesthesia. Neuraxial is if you do some kind of numbing around a patient's spinal cord, and regional anesthesia is where you numb like a nerve going to like the arms or legs or something like that. So the first spinal ever was in 1898, and the only local anesthetic, the first local anesthetic available was cocaine. That was the only thing that was available. So they injected cocaine into a dog's spinal fluid and realized the dog was walking around dragging its back legs. So then they were able to use that on patients to numb from wherever they injected it in the spinal column and that area down. So they could do operations where the patient wouldn't feel any pain but could be awake. So it was a great adjunct for patients who were like very sick, couldn't tolerate ether anesthesia. Caudal anesthesia is just another way of injecting like down by your sacrum, down by your tailbone. And then there were different advances in this over the years, but ultimately ultrasound, which is a relatively new technology. It's been around some years, but the use in doing nerve blocks and regional anesthesia has taken off recently. So now you can look with an ultrasound probe, which in the middle here at the bottom, that's an ultrasound machine. There's a probe that delivers a sound wave into tissue, and whatever sound is reflected coming back to the probe gives you an image on the screen. And the color of things on the image give you an idea of what is the tissue. And on the right, here's an example. There's a needle coming in here. This round white thing is a nerve. And using the probe, you could put the needle in and watch the needle go exactly next to the nerve, and you can inject the local anesthetic precisely around it. Before, we would just do this by landmark, look at where the bones were, estimate where the nerve was, and put a needle in, and use like a nerve stimulator. And if the arm or leg started jumping when you were close, then you had an idea you might be there, but the success rate was much lower. And this has changed over the past, since my training. When I trained, we did a lot of these without ultrasound. Medications, one of the bread and butter things of anesthesia. So we don't necessarily think of that as a technology, but it is a technology. It takes a lot of technology to develop medications. The early anesthetics, 1922, we were using ether, chloroform, and nitrous oxide. Patients were getting liver disease, the kidney disease. All of these things were highly flammable, so it wasn't unheard of for the operating room to light on fire. Any kind of match surgical instrument that sparked could have lit the whole surgical field on fire because ether is highly flammable. So it was a real danger. Even anesthetists were getting sickly by the time they got to the end of their career because they were breathing ether all the time. So halothane was an agent that improved greatly over those, but it caused a lot of low blood pressure and some arrhythmias, but it wasn't flammable, so that was a big change. But the modern drugs are overall very safe. We mostly use these inhalational agents, volatile anesthetics that go into breathing circuit and keep the patient asleep for the case. And we also give IV medicine to get them off to sleep. And sometimes we do an anesthesia just giving medicine through the IV the whole time. It just depends what we're doing and why we're doing it. There are many options nowadays, but the safety profile of these medications are much, much better than they used to be. And I wanted to point in here as far as devices go. Here's an example of like the built-in warning system. Sometimes you might order a drug or put a drug in there. The electronic health record now has the ability to alert you and say, hey, if you give this drug, it might interact with this drug that the patient's already on. So it's a nice adjunct and something that's changed over recent years. Here, we'll skip over this because for time's sake, but this is basically just like a timeline of kind of what we went over.
Seth, we're about to run out of time, so we're going to send you out a new Zoom link.
Okay, all right, perfect. I'll get the new Zoom link in a second and I'll log on.